Okay, our presenter today is Robin Golden. Robin is Associate Vice President of Population Health and Aging at Rush University Medical Center in Chicago. Recently, she served as a member of the National Academies of Sciences, Engineering, and Medicine's committee studying the integration of social needs care into the delivery of healthcare. And with that, I would like to turn the floor over to our presenter, Robin Golden. Welcome, Robin.
Thank you, Steve. Good morning and afternoon, everyone. So good to be here with you. So I'm just going to go over the learning objectives. I'm going to describe the report that just came out in September, and then I'm going to talk a little bit about key recommendations and opportunities for action for stakeholders in community-based organizations and the Aging Network. And I'm going to talk about the study and explain the study in context of the various initiatives across the nation that are addressing inequities in health and well-being by making healthcare more responsive to social needs. So I think most of you know this, but to just level set, we know that many facets of life influence health and well-being. The Flourish Index, developed by Anna Fall and Herc Webb at University of Illinois, is an overall score, and I love showing this. It's an overall score to gauge how much someone is flourishing. I like this because it's very much a strengths-based way of thinking about older adults. It's compiled of 36 domains that capture current status of an individual's life and health, from a balanced test to a PHQ-2 for depression to access to dental care. It was developed and tested only with an older adult population. I like the index because it succinctly captures the diverse things we know that influence an individual's health and well-being. So you can read more about that at some point. We adapted the language a bit, but they outline these key categories of areas that influence health: biological factors, environmental, health services, mental health, individual health, and socioeconomic and structural factors. So let's put this into perspective. At age 50 and 65, we see persistent inequities in how many more years a given individual will live based on income and race. That is stark proof of the cumulative effect on individuals of a lifetime of exposure to negative structural factors in society, such as racism, bias, historic exclusion from certain systems, and the resulting lack of generational wealth, as well as to adverse socioeconomic conditions, such as having a low income, living in a transportation desert, or lacking familial and thus caregiver support at home. This graph, which I hope you can see, is from a Washington Post story that found that as of 2010, the average upper-income 50-year-old man was expected to live until age 89, and upper-income 50-year-old woman to 92. But the same man and woman, if they are lower income, would live to just 76 and 78, according to the report. 13 years shorter for the man, 14 years shorter for the woman. That is huge inequity in projected health outcomes based on your life situation at 50. We also see gaps in life expectancy and other health and well-being indicators by characteristics such as race and ethnicity, disability status, living alone, and many other factors captured in the Flourish Index, which I just showed. So working in healthcare and social services for older adults, the questions become, what can we do to mitigate the tough situations that many individuals and families find themselves in? We know many of them will turn into healthcare problems down the line that could be prevented if there had just been more stable transportation or easier to cook healthy foods available nearby. So there's a critical role for the Aging Network and for social services. There's growing evidence showing the majority of healthcare costs are driven by factors outside of the clinical environment, the so-called social determinants of health, leading to the notion that social care is healthcare. In an Elizabeth Bradley and Lauren Taylor study published in 2016 in Health Affairs, their team analyzed associations between states' ratios of healthcare and social service spending with outcomes. They found that states with a higher ratio of social services to health spending, which was calculated as the sum of social service spending and public health spending divided by the sum of Medicare and Medicaid spending, that it showed better health outcomes on measures such as the number of days with activity limitations and mortality rates for type 2 diabetes, lung cancer, and heart attacks. We know that the Aging Network, Centers for Independent Living, and other community-based organizations are poised to keep addressing social determinants needs through nutrition, home care, transportation, evidence-based programs, social engagement opportunities, caregiver supports, while also expanding their reach by partnering with healthcare entities and being hubs for a variety of home and community-based services. Now that the health sector has recognized a bit more the importance of addressing health-related social needs, AAAs are entering into partnerships and contracts to provide programs and services to MCOs, health systems, and other healthcare providers, such as providing care management, transitional care, and caregiver supports. In N4A's 2018 member survey about contracting and cross-sector partnerships, it found that nearly 44% of AAA respondents reported having at least one contract with a healthcare entity, and an additional 16% were pursuing contracts. While this is an exciting trend for those of us who believe the healthcare sector should buy our aging services in the community from existing entities who are rooted in the history of that community, we still see the challenges that CBOs face in getting buy-in and getting to a contract. And we know that there's there is a lot for us to learn about the best way to connect and integrate social and healthcare. In 2016, a group of us recognized the need to coalesce the field and highlight some of these issues with an independent review of the ways that healthcare is addressing social determinants of health needs and the role that social workers and other providers play in that work. To answer a question like this, the National Academies seemed like a natural place to turn. In 1863, President Lincoln signed a congressional charter forming the National Academy of Sciences to investigate, examine, experiment, and report upon any subject of science or art. Since then, the Health and Medicine Division of the National Academies, the former IOM, if you will, Institute of Medicine, has done so much important work over the years to bring national attention to issues and evoke change. They produce consensus studies that include respected, evidence-based consensus recommendations, a way to reach key stakeholders and broad audiences. For instance, in 2001, there was Crossing the Quality Chasm, which really spurred a focus on quality in healthcare. In 2002, there was a study on unequal treatment, confronting racial and ethnic disparities in healthcare, which really was a mainstream recognition of disparities and inequities in the U.S. In 2008, something near and dear to our hearts was Retooling for an Aging America, which became the Elder Care Workforce Alliance. In 2010, there was a Future of Nursing report, and then in 2015, a Psychosocial Interventions for Mental and Substance Use Disorders. These are just a few of so many reports that have been done. So after talking with a lot of leaders, previous studies, and some National Academy staff, we pursued a consensus study looking at ways that healthcare is addressing social determinants of health needs and the role that social workers and the Aging Network and other providers play, and to make recommendations on how to move us all forward to make the most impact. We worked with various stakeholders, including N4A and ASA, to hone what the study's statement of task is. The official charge of the committee would be, and you can see some of it here on the slide. The statement of tasks ultimately opened up beyond social work to social needs and social care broadly, charging the committee to look at both the need for integrating social care as well as specifically at the how of it. The committee was to address and examine ways that healthcare systems address social determinants of health, both evidence-based and emerging, evaluate roles of health professionals across the care continuum. Gerontologists were shouted out a fair amount in this report. Review evidence of impacts of social needs care on patient and family caregiver health and well-being, patient activation, healthcare utilization, cost savings, and patient and provider satisfaction. and ultimately to discuss opportunities to advance social care integration with healthcare to improve health outcomes and reduce health inequities. As I kind of try to talk about it, it reminds me a lot of rebalancing long-term care from the more institution to the community. We were trying to rebalance healthcare in this from more the medical, four-wall hospital side to the community and more the social care. There's an analogy there. I hope it moves faster than long-term services and supports has. Just a comment. There were many, many funders in a coalition that we put together that were local and national philanthropic groups, as well as a broad coalition of social work funders, academic programs. We had 64 schools of social work pitch in for this study, and it was just quite amazing. There was a match campaign from Boston University, but it was so amazing for the big funders like Robert Wood Johnson and Archstone to see that so many people chipped in, so many of the key stakeholders, that it was very impressive. There were 18 of us on the Consensus Committee, a diverse group. The committee's members have expertise in fields that include social work, nursing, medicine, public health, gerontology, healthcare financing, healthcare technology, the healthcare workforce, and health insurance design. And they came from academia, the private sector, and government entities. I was lucky enough to be one of the folks on the committee. It was an incredible committee. We worked together for almost 2 years, if not longer, and the process is quite an interesting one. Over the course of 18 months, we started by collecting information. This included literature review for peer-reviewed pieces and, luckily, the quote-unquote gray literature submitted through the website and identified by committee and staff. We were lucky to look at the gray literature because, unfortunately, a lot of our wonderful work in our field has not necessarily been written in journals. So it's very, very important that we try to look at best practices beyond randomized control trials and what was written in a peer-reviewed journal, because we didn't miss anything. We invited presentations at public meetings from a number of different community-based and governmental stakeholders. Then we reviewed and analyzed the evidence base. Over the course of a couple in-person meetings and lots of committee work in between, we organized our thoughts and worked to find consensus on our findings and recommendations. Then we summarized the evidence, findings, and recommendations in a report. Then the report went out for external review for several leading experts to weigh in on the gaps in our draft or any problematic issues. And then we addressed all the comments and finalized the report with all the committee's consensus on findings and recommendations. Not an easy process, but a most interesting one, an informative one. So, as I mentioned, we heard from a lot of stakeholders. We heard from Christy Kolinsky at ACL. She talked about ways that the Aging and Disability Network services align with value-based care, the ways CBOs can help with activities like engagement and home visits, and the need for community-based organizations to be supported with business acumen and data infrastructure. Susan Reinhardt from AARP talked about caregivers and the CARE Act. Catherine Haslinger from JASA in New York talked about the diverse services their agency provided and what the value is of the community-based organization in supporting older adults in New York. She really was very succinct at drawing conclusions between the psychosocial needs her agency provided and then along the lines of helping people with economic stability and social connections and what a difference it made. And then Laura Taylor also talked in great detail, she's from the VA, the head of social work there, about their strategy to provide comprehensive primary care that's responsive to social care needs. Then, given the statement of task focus on care models that facilitate the actual integration of care, the committee invited a few additional presenters to speak about some of the models. Some of my colleagues here at Rush talked about our social work evidence-based transitional care model called the Bridge model. Then other folks talked about ambulatory, putting social workers or aging network folks inside primary care. And we also talked a lot about what matters to patients and integrated some of the age-friendly health system work that's going on. as a prompt that could encourage hospitals to be more attuned to the psychosocial factors we know are so important to individuals and families as we age. So that was also an important one. We also looked at some of the work that came out of the Innovation Center, or is supposed to be coming out of the Innovation Center at CMS, around accountable health communities, because if some of you remember that call or RFP that went out a couple years ago, it really gave a nod to the community. We were supposed to screen for social determinants in emergency departments and then send people with greater social risks to the community to get their risks attended to or their needs attended to. What's interesting in terms of a payment structure, there was very little that would go beyond just talking about going to the community, not necessarily payment that followed. So that's a big piece of this report, is talking about how do you fund this very necessary work. One of the first things we did was really try to organize and align our language. It was a significant part of the report, and we decided to lay out definitions to talk consistently about this, viewing health very broadly, defining social care as activities that address health-related social risk factors and social needs, defining social determinants of health by building on the World Health Organization's definition, which is the conditions in which people are born, grow, work, live, and age. Then we recognize that social determinants are not necessarily positive or negative. We said that they are associated with negative health outcomes and that they are social risk factors. And social needs, we talked about in individuals' responses to a social needs screening intentionally, a person-centered concept that incorporates a person's own perception of his or her own health-related needs. So again, that person-centeredness. And then, of course, we talked about what social services are and that it's one type of social care. We talked about social care providers in this report. Some of us were a bit mixed about this concept. And the committee included various backgrounds in what they defined the social care workforce to be: nurses, physicians, social workers, community health workers, direct care workers, home health aides, navigators, family caregivers, care managers, gerontologists, medical legal partnership attorneys, and many others. So we had a hard time covering everybody. In addition to our common definitions, we needed a taxonomy and framework to organize evidence about how systems address social risk factors and social needs. We came up with the 5 A's: awareness, adjustment, assistance, alignment, and advocacy. And we really did see this as a template for people to organize their work around social care and to measure how far they're going with social care. If we are thinking of transportation as so awareness really is activities that identify the social risks and assets of defining patients and populations. So let's use transportation as an example for all of this. An example of awareness would be asking patients or clients if they have a way to get to their appointments, the grocery store, and other places they need to be healthy. Or it could be conducting research about transportation gaps in your community. So that's 1A. Adjustment are activities that focus on altering clinical care to accommodate identified social barriers, such as reducing the need for in-person healthcare appointments by, for example, using other options such as telehealth for appointments. Assistance are activities that connect patients with relevant social care resources and thus reduce social risk. So an example related to transportation would be providing transportation vouchers so that patients can travel to healthcare appointments. Alignment are activities to understand social care assets in the community, to organize them, and to invest in and deploy them to improve health outcomes. So this would be something like investing in community ride-sharing or time bank programs. And last but not least, advocacy, activities in which healthcare organizations work with partner social care organizations in the aging network to promote policies that facilitate the creation and redeployment of assets or resources to address health and social needs. So that the transportation example there would be to work to promote policies that fundamentally change the transportation and infrastructure within the community. So you have a sense that there are individual, more micro activities related to the 5 A's and more macro. And really it takes all of them to be integrated into order to make that difference. I want to segue into some of the committee findings. After making our framework, we reviewed, organized, and analyzed the literature we found, and leading us to conclude that 3 key areas need to be addressed in order to enable successful health social care integration. Each of these necessities requires system-level change. The first one is an appropriately staffed and trained workforce. The committee stated, all members of the healthcare team should be aware of social factors, but experts in social care are critical to interprofessional teams. It also continued to say social workers are specialists in providing social care and have a long history of working with healthcare delivery. So that was a real shout out to the team, and including as the team, not just people sitting within the context of a hospital, but those people who are the community-based organization, the direct care worker. We also found that part of having an appropriately staffed and trained workforce is having role clarity among team members and skill building for working in teams, on teams. Federal, state, and institutional barriers limit reimbursement for activities delivered by social care workers with healthcare delivery. That's also something we found under workforce, because if you're not going to have an appropriately staffed and trained workforce, if there really isn't some payment structures for people to do this work. So it's kind of a hand-in-glove approach, and both need to happen. The second really has to do with health information technology innovations. Interoperability and data sharing between health and social care are hampered by a lack of infrastructure, data standards, and modern technology architecture shared between and among organizations. We recognize that advances in technology have the potential to facilitate the integration of the healthcare and social care sector, but also that the local efforts to share healthcare and social care information are not supported by a national strategy or coupled with resources. This is something that's been talked about forever. And how I really boil this down is that the physician seeing our client patient should know what the direct care worker in the home is thinking, and the direct care worker in the home should know what the physician is thinking. And until we figure out a way to talk to one another that way, in that form, we're going to still not really meet the needs of the people we're serving. And then the third area of our findings was new financial models. The legal definition of healthcare uses different kinds of ways to include different parts of different workforce within the healthcare sector. So that needs to be clarified. Methods of paying for healthcare can incentivize or disincentivize the inclusion of social care in healthcare delivery. Value-based payment structures align incentives for the provision of social care, and that there's an administrative capacity issue for many aging network and social care providers. It's a limited one. You hear community-based organizations talking about working with some of the new resource-curated directories like Healthify, Aunt Bertha's, NowPow, and hospitals choose one to work with. But then the community-based organization needs to work with all those hospitals, and how can we possibly think that they can learn all that and integrate all that with an infrastructure that's not as robust as it needs to be? So for these findings, the committee developed recommendations in 5 major areas, and the following slides cover select recommendations from the report. So there was a spotlight on community-based organizations. Throughout all of these discussions, the theme was the important role of existing CBOs who have been in the trenches and in the homes providing care, social care in particular, often on shoestring budgets or in a state government behind on their bills. Partnering with healthcare holds so much promise, but these partnerships can be challenged because of the power imbalances and training and workforce retention issues. Another piece that we've seen is that it has to be a true two-way partnership with a committed healthcare stakeholder for a cross-sector initiative to truly catch on and to be effective in making a less siloed care ecosystem for the patient. And the tough thing is that there isn't enough healthcare investment upfront, the operational changes needed to refer to this new initiative. For instance, our not willingness to share discharge plans with a community-based transitional care coordinator. Then the initiative might look like a failure or no fault of the CBO. So we really have a breakdown, and that goes back to silos and often blaming each other as opposed to really remembering that we all have the same goal in mind for the patient client we're working with, and thus we need to be a team and work together. There was also a spotlight on social work. I mentioned workforce scope of practice, financing needs in two key areas. The quote from our report highlights a key example that crosses both of these areas. Clinical social work is seen by Medicare as related solely to the diagnosis and treatment of mental illness, not including a lot of the other tasks like assessment, care management, psychoeducation that social workers do to support Medicare beneficiaries. This definition and CMS's unwillingness to broaden it without legislation has made it very difficult to get local Medicare administrative contractors to recognize social workers as qualified health providers to use such codes as health and behavior assessment and intervention services, which reimburse for social work's bread and butter, services that target social factors that are affecting or that result from physical health problems. Social workers staffed within CBOs could get approved as Medicare providers and then have a sustainable revenue source to support these types of services that can fill the gaps based on community member needs, not just based on what grants or contracts you were able to get. So this is really a critical piece that we are going to continue to work on. So how did we get there? And here's the 5 consensus goals. And we talked about designing a healthcare delivery structure to increase social care into healthcare, to integrate social care into healthcare, to build a workforce to integrate social care into healthcare delivery, to develop a digital infrastructure that is interoperable between healthcare and social care organizations, and finance the integration of healthcare and social care. And then the last was to fund, conduct, and translate research and evaluation on the effectiveness and implementation of social care practices in healthcare settings. So they're not necessarily sequential, they're all critical, and I'll get into them in a little more depth. Our committee's first goal area was to design healthcare delivery to better integrate social care, and thinking along the lines of the 5A activities I reviewed earlier. We recommended that healthcare organizations design and implement integrated care systems by engaging diverse stakeholders, by supporting the development of infrastructure components needed to meet the goals of integration, to establish linkages and communication pathways between healthcare and social service providers. Don't go at the 5 A's alone, for example, and always build out things on your own. Leverage your community-based partners. That was our message to the health systems here. Hopefully they heard it. I know that the Aging and Disability Business Institute has been trying to get that heard for some time and doing a great job, but I think everybody would agree we're not there yet, and we can use this report as some leverage. And to really then develop and finance referral relationships with selected social care providers when feasible. We must be aware of building demand without funding capacity. So again, speaking to that, we can't just layer or expect that CBOs and the aging network will pick up the pieces without financing us to do so. The second goal was a big one, to build a workforce. Looking at state legislature, licensing boards, professional associations, and federal agencies, that we should develop, expand, and standardize the scopes of practice for various social care providers. We really did talk about the importance of team, but we also expressed we need to sort out who does what on the team. And that we should be, many of us should be considered to be providers who are eligible for reimbursement. And we also looked at the future of health professionals and the importance of educating them on social risk factors and how they affect health, and train folks in their different ways of training, medicine, nursing, social work, gerontology, whatever, on how to work in interprofessional teams. And it was the message really, and the funding should include this. It should incentivize teamwork. And that's part of what's going on, is it's really disincentivized now, if anything. As part of this, we talked about even engaging some of the experts in social care in instructional roles. So social workers might be teaching in a medical school about social determinants, not the intent that the physician needs to become the social determinant, social risk screener expert at all, but he or she needs to be able to call on the team and to provide who can then provide information in a way to meet the needs that they're identifying. We were not ever suggesting that everybody has to know the same, but that we should share the knowledge from the experts and know who does what on a team. And finally, workforce is a big area with lots of recommendations, and our recommendations also included the importance of teaching in a continuing education way to build competency-based curricula on social care. That everybody, care managers across systems, everybody needs to understand not only what their role is in social care, but how do they speak at a table with a team. Sometimes there's that hierarchical aspect of our work, and how do you help people voice their concerns and stand behind their voice in order to best serve the patients and clients that we attend to. So we really tried to also think about raising awareness and building a campaign to raise awareness of this work. The third goal was also a huge one, to develop this digital infrastructure, calling on various activities that could be undertaken by the private sector or the Federal Office of the National Coordinator and supported by existing legislation. There's a lot of work that's been done to try to fix the situations of the lack of interoperability between the community and hospitals and vice versa. But it hasn't been implemented. But there is kind of a map that's there that has been established in other administrations through the ONC. So we need to provide support for states to identify these interoperable platforms for communities and utilize them. And importantly, focus on equity in digital and technological advances, working on issues such as, are solutions available in rural areas? Are organizations that serve individuals who speak English as a second language being given the access they need to meaningful collaboration? Is there a clear governance structure in place with multiple referral platforms? All of that needs to be attended to and critical. And if you look at the report and download the report, you'll see very clear pathways to get to that. The fourth goal is to finance social care with recommendations that are for Medicare, Medicaid, looking at regulatory action, trying to clearly define what social care is considered and what's covered by Medicaid, by waivers, all of the things, areas we work in. Considering additional Medicare reforms to broaden coverage rules. It's great that Medicare Advantage is now starting to get access to expanded supplemental benefits. Maybe that includes social care, but what will that mean? What does that mean for fee-for-service Medicare? All of that. We think there's a lot of hope in the value-based future, that we're going from volume to value when we look at health care, but we need to make sure social care is very much at the table. Theoretically, we think it will be, because we all have seen the results internationally that when you attend to social care, your health outcomes are improved. So hopefully that will be how we look at things when we're paying for outcomes, as opposed to just doing the episodes of care. And there's a lot of coordination that needs to be done in terms of at the state level. We also need to communicate proactively to health plans and healthcare and social care providers about social care activities that can be covered. pursue policies of continuous program eligibility to minimize disruption and maximize access to care. And again, pursue opportunities that could align hospital licensing and reporting requirements in ways that ensure consistent obligations for health systems with respect to community benefits. This was discussed a lot. Nonprofit hospitals keep their nonprofit status by investing in the community, and maybe they need to be investing in some of the organizations where we are employed in the Aging Network and other CBOs. Very important point. How do we turn that around? And then the last goal, really, again, a big one, was to fund, conduct, and translate research and have greater evaluation related to integrating social care with the delivery of health care. We'll have a lively discussion about that one today, I'm sure. Some people feel that there's enough research has been done. Other people feel that there hasn't. Overall, I think we need to understand our impact and be able to discuss our impact in more concrete ways than we do. We don't want to lose the qualitative of telling our story. Never, never, never. But we do need to be grounded in numbers and outcomes in a way that really tell the story, show our impact, our return on investment, whatever you want to call it, or business case, that both address individuals who have unmet needs now and to minimize social risk factors in the future. We encourage federal and state agencies, payers, providers, delivery systems, and foundations to contribute to advancing research on and the evaluation of the effectiveness of social care practices. And we want to look at some potential demos that show this a little better. Demos particularly between the hospitals and community-based organizations that really do show what a difference them working together makes for overall health outcomes and well-being for the people we all serve. There are a lot of best practices outlined. We really believe we need to develop a common core of measures that diverse stakeholders, including patients and families, care about. Get patient and family input into what we're looking to do. So we're building on the report. We're doing a number of things to disseminate, and just like what we're doing today with almost 500 people on the phone, using the hashtag social care and using a social media toolkit provided by the National Academies is all on the website, such as this infographic that indicates that social care is health care. Through our own Center for Health and Social Care Integration at Rush, we're also working on various efforts to disseminate the report so that others can reference it, to elevate their work in context and to have some common language. We've done this through various webinars, a number of conferences, also local convenings. We just had one in Chicago last week and hope that there will be other local convenings. There's one planned in Milwaukee. I know a bunch of the supportive funders like Archstone Foundation is trying to have one in Southern California. Hopefully there'll be one in Northern, one in Boston, one in Washington. The more we can take this report and make it real and apply to the areas where we live and work will really make a difference. And there's a lot of alignment between N4A, the elder care workforce, NASW, Council on Social Worker Education, many of us trying to get together. We've had some really good luck on the Hill thus far, gone to the White House, gone to Medicare, gone to MedPath in a very short period of time. Not that anything's going to dramatically change, but we need to keep working at it and not let it go because you know how critical it is for the future of our care. So on that, I'm going to open it up to questions, concerns, whatever you might like to say. Steve?
Okay. Thank you very much, Robin. Great presentation. It is time for the Q&A section of today's hour. So if you have any questions for Robin, what we've been talking about here, please type them in right now using the questions box that you can see on there on the screen, and we will get to it here. The first question for you, Robin, how were the 64 social work programs selected?
Oh, we sent a great, they weren't selected, they volunteered to give money toward the report. I don't think I specified this. It cost $1.2 million to do a report with the National Academies. And they don't have the money to just give you to do that report. You have to fundraise for that money. So that's where that coalition of social workers that we got together to contemplate this report really reached out to all of their other social work colleagues who are part of organizations, membership organizations, and or schools of social work. So they volunteered. And it was pretty impressive that so many of them volunteered.
Okay, thank you. Next question. Who can pay for the rebalancing of health care to the social service domain in the working poor population, which does not have Medicaid or adequate private insurance? What is the advocacy campaign to make this happen?
Great question. And as you can see, I don't think we touched on that enough. We talked about Medicaid, we talked about Medicare, but we did not talk about, for example, people who are undocumented, people who don't, have those kind of benefits. We didn't spend a lot on it. Who can pay for it? I'm not sure who can pay for any of this or who will pay for any of this, but I think there's a wish that people still get served. And how do we boost up the community organizations that are best serving them, and how do we make that connection with hospitals? And that may be, again, to look at community benefits, and many hospitals also have what they call an anchor. It's their anchor institutions, which is they're investing in their community around that they serve, the geographic areas that they serve. So that may be another mechanism to pay for those types of things. But it's a tough question. Love to hear some other thoughts about that if you have any answers to that.
Yes, anyone, if you do have any further thoughts, please send them in. This is a discussion time, so it doesn't have to be questions only. If you have any comments or anything like that, certainly welcome. We've got a couple questions here, which I'm going to kind of lump all into one here for you, Robin. Is the report public? Can it be downloaded? Do you have a website to provide for that or something along those lines?
Yes. Don't I have it up there? What's the last? Can you go back to the last? Or I guess I can. Oh.
Is that right there?
You can get it from our website, or you go to #SocialCare to get it, and you just go on to the National Academies of Science, Engineering, and Medicine website, and you type in social care and it'll pop up. And it's not only the 70-page report, which is fascinating, of course, to read in detail. I think it is, even though, for a while I didn't think I could look at it again because we also write the report. But there are some nice downloadable handouts that are 2 or 3 pages that are a summary of things. And hopefully there will be some future 3 or 4 pagers that are more about the aging network, more directed to CBOs, more directed to social workers. So we're hoping that those will come out soon. But absolutely downloadable. Take it, take the slides, take my slides, talk about it. Please create a campaign with us. If we don't start talking about this very openly, it's not going to change. Important thing to ask our future candidates about these questions as well.
Okay. Next question, Robin. If someone was interested in being part of a committee, how would they go about doing so?
Yeah, I think of a committee in general or around this topic. If you're interested in this topic, please email me, and maybe, Steve, you could send out my email somehow.
Yes, folks, the Robin's email is on the slides here.
There we go.
If you want to download them, they are part of that. They are, actually, I'll put that up on the screen here for you.
There it is.
You can see her email right there. You can download this as part of the slides, folks. It's in the PDF there, so if you want to get a hold of Robin, there is her email right there. Let's get back to the questions here. Robin, next question. To increase collaboration between for-profit organizations and CBOs, what are the top 3 metrics you recommend we begin tracking to seek funding?
Well, if the for-profit entities are caring specifically about outcomes, such as reducing readmissions or keeping unnecessarily visits to the emergency department down, those sorts of things, or just reducing admissions totally, or reducing spending. If that's what you mean, more the insurance industry and that sort of thing, you need to buy into those metrics and show how your work is having an effect on those things. It's tricky sometimes, but it's amazing how more and more people are doing just that. So there are ways to do that, and we can talk more about that at times. If you're talking about some of the for-profits that are popping up that are doing our work that many of us have been doing in a nonprofit status our whole lives, I think it's really critical to try to hold them to the notion that you know their communities pretty well and that you can help with whatever their mission and vision is. Now remember, their mission and vision includes a profit. So how do you connect to what their biggest interests are and how you might help with that? And I think it's really important that we not walk in like they are bigger or more important than we are. We need to walk in on an equal footing, or bring them in. That's even a better way to do it. Bring them to come and see you and what you're doing. I think there's ways to do it. I think everyone knows that the future is not going to just be about government systems of payment, unfortunately, but it's going to have an integration of private and nonprofit and government, all included, businesses, etc. So how do we make that happen, and where is it happening? And I think there are a few places it's happening and happening well. And how do we replicate that and get those for-profit entities and those organizations to talk about the value to other businesses? Use them as spokespeople if they're saying good things about your work. Use them to talk to other folks. And let's look nationally about who's making that difference with those types of people, and how do we open more doors for the rest of us.
All right, very good. Next question. When you met on the Hill and with Medicaid and Medicare, what were some of the outcomes and results?
A lot of nodding of heads, a lot of interest. For example, when we met at the White House just last week, the current president put out an executive order, which we may not agree with us, most of us, but there was a clause, and it's about not having ultimately Medicare for all, trying to stop Medicare for all, okay? So we may or may not disagree with that. I don't necessarily agree with it. But there was a caveat in the executive order that basically said something to the effect of other disciplines should be involved as part of the team and be able to bill and be able to provide services beyond the physician. So we picked up on that language and said, okay, we may not agree with the overall essence of this, but there's a caveat in here that we could play on and talk about. So when we went to the Hill, we talked about that, and the person who wrote that executive order was in the room and really connected to what we were saying. So nobody promises anything if you've been in these situations. They seem interested, they're polite, they try to help you make connections to other things. CMS helped us think about regulatory changes, statutory changes. So we have a lot of to-dos after leaving those offices, but nobody said to our face, this isn't possible, or social care is, not significant or not important. Everybody really believes it is. So that was promising. So I think it was more optimistic than not. Do I think there are any quick answers? No. I think we know how slowly things move everywhere, but particularly in our different aspects of government. But I think if we stick with it, we're going to get somewhere.
Okay. Next question. There has been a host of successful pilot projects that demonstrate the integration of health and social programs. The inability to sustain them always comes down to funding. Please let us know if there are specific changes we can advocate for as a group through federal agencies and our congressional delegations.
Take this report. That's what this report says, exactly what you're saying, and why some of us are so interested in spending time in Washington. I was very frustrated after 25 years of being a social worker in the aging field and developing really wonderful programs, and the program would go away when the funding went away. And I wanted to understand policy levers a little more in which things could be sustained. Now, do I have the magic answers? No, but I understand it a little better and know that everybody feels the same thing. And without doing that kind of business case and evidence and proof, not only to our legislators, and those could be nearby, your state folks, your U.S. folks, go to them when they're not always in Washington, the U.S. folks. They spend a lot of time in their districts. Get to know them. Talk about this report. Talk about how they can help you implement aspects of it and think about funding in a more braided way.
Okay. Next question. Could you please talk a bit more about research and evaluation opportunities on the integration of social and health care? What would you suggest an early stage researcher to do, or which institutions to actively reach out to for funding opportunities or to carry out this work?
Well, part of this is our academic downfall in that we don't support health service research enough. People get a lot of attention in academia for doing randomized control trials and things such as that. That's viewed still as the gold standard, when really we need someone studying why a home-delivered meal makes a difference, why a transportation rides to whatever it may be makes a difference, why social isolation programs make a difference, and why having a care manager help people through that in order to decide and determine what they need, what they want, and help them fulfill those needs and wants. That's critical too. But how do you measure that? That's where research needs to be directed. And where it gets funded, I think we say loudly in this report, it needs to get funded by PCORI, CMS, places like that. NIH needs to look beyond very quantitative design and think more about health service research, community service research, all of the above. And again, I think there are a lot of nods to that in this report, that we need to look more broadly than the way we are and to be able to prove our effectiveness.
Okay. Robin, what are some places that you see this is happening well, the collaboration with for-profit and CBO-centric?
For-profit, meaning, I'm not sure what people are meaning when they say for-profit. If they're meaning healthcare entities, I think there's some great stuff going on and I was just talking to folks at ACL, and I think the Aging and Disability Business Institute knows some great places too. But I think we're all watching Tennessee, we're watching North Carolina. There's some great stuff coming out of Partners in Care Foundation in Southern California. Still some good things coming out of Massachusetts. We have trained at Rush about 150 folks, probably some of you on the phone, in some of our models of care that have shown effectiveness, and we have a lot of the places that we've trained in the Aging Network who have been able to contract with hospitals and payers near them to make this happen. And we had United Health Group here today from Minnesota. They came to Chicago to see some of our examples of what we're doing, and they are, when insurance companies start to pay for these things, they're paying for housing, they're paying for transportation, they're paying for food. It's kind of miraculous, and the fact that they've done enough research to prove that this makes a difference is very significant. And to say to those people around you, the for-profits, hey, payers are paying for these kinds of things that we're talking about, and even to study the effectiveness of it, how can you be part of this movement? Ultimately, it will help your bottom line because outcomes will be better for folks. And I think as time goes on, it's going to be an easier sell.
Okay. Next question. As a director of direct services, in-home direct care, nutrition, transportation, advocacy, et cetera, how do we encourage our state unit on aging and Office of Medicaid to incorporate this into future planning?
Great question. So, for example, California's such a good example about their state plan on aging. I'm sure this is being discussed, but I know our new plan on aging and our new director of aging in our state has very much included social determinants as its own. I think they have 6 priorities for next year in their strategic planning, and social determinants is one of them. So it's that kind of infusion that's going to be critical. And at their leverage, if they have anything to do with managed care, long-term services and supports, they need to say things, or even someone who's somewhere directing all these Medicare Advantage plans, if there could be greater mandates, if you will, to say you must play in the community-based world and the aging network world rather than develop your own services or not trust what's already been there for 25 years. I mean, that has to be pushed and pressured. And again, I think it will be over time. I think there's some movement, and I do think there are possibilities with Medicare Advantage to get some of this paid for. And for the research question on the phone, you know, these Medicare Advantage places, if they have any evaluation positions, that would be very interesting to be part of evaluations by some of these companies who are promoting Medicare Advantage and measuring what investing in their supplemental services, as they're calling them, how that makes a difference.
Right. More of a comment here for you, Robin. Excellent presentation, Robin. Thank you for this great information about this critical initiative to ensure healthcare systems are responsive to social needs and what is being done to support.
Great.
Back to the questions here. We got time to squeeze 1 or 2 more in here. Does the report talk more in detail about the challenges faced with trying to standardize roles for the workforce, licensing, et cetera, and creating agile models for onboarding new employees?
It doesn't talk about that specificity of onboarding employees, but it talks about the fact that when you've met, you know, the difficulty when you've met one AAA, you've met one AAA, or when you've met one social worker, you've met one social worker. How do we develop greater standards of care that cut across so people know that they're getting common interventions and standardized interventions? So we do talk about that.
Okay. How are the Medicare Advantage plans able to provide case management for patients with a person-centered focus? And this is not always provided through traditional Medicare.
Well, I don't think I've said that yet because I'm not there. But at least they're nodding to the fact that they are saying they're going to look at people more holistically. So that's where we need to, you know, monitor it or observe or try to influence what they're doing and what they mean by person-centered and paying for more than just your traditional medical model sorts of things. So I think time will tell, but again, how do we get that looked at? And that's a place where I wish if we have time to influence the Innovation Center or influence ACL to have, and I know they're very interested because this is a big part of their intention along with N4A, how do you get some demos through CMMI, the Innovation Center, with ACL to show some of this? I think it would make a really big difference.
Okay. Well, Robin, unfortunately, we've reached the end of our hour here, and we're just about out of time. But I want to thank you for a great presentation and joining us.
Thank you so much, and don't hesitate to reach out, okay? Thank you all. Thanks, Steve.
Thank you, Robin. It's time for us to wrap up, everyone. We do appreciate you joining today's webinar.